I'm Chris Wiseman, and this video is to demonstrate the 6 airway manoeuvres and a common error with each one. I'll now demonstrate placing a patient in a lateral side position. I've got my standard precautions on and place myself at the preferred hip of the patient. I'll bring her near leg up to a 90-degree angle and place her far arm out, other arm across her chest for stabilisation. Now, a common error here would be if I was to place my hand on her shoulder and her knee, as this would not maintain her natural spine curvature. So I'll place my hand on her hip and rotate away from myself, putting the patient's knee down again at a 90-degree angle with her hand under her head and her other arm out, and check for breathing and airway. I will now demonstrate the triple airway manoeuvre. I position myself at the patient's head and place a pillow underneath his head to provide support and neck flexion, making sure his external acoustic meatus is in line with his sternal notch. I'll then place my right hand on the patient's forehead and my left hand on his jaw, providing head extension, and then placing both my hands on the jaw with my 5th, 4th and 3rd fingers underneath the mandible, my index fingers on the mandible and my thumbs on the zygote, providing jaw thrust. These are the 3 components of the triple airway manoeuvre. I would then look, listen and feel for breathing. A common error here is if the head is hyperextended or if there's not enough support underneath the head, as these would both cause a kink in the airway and there would not be patent breath flow. I will now demonstrate how to insert an OPA airway. I'll have the patient in the triple airway position and I'll measure the OPA from the corner of his mouth to the angle of his mandible, and I'll insert the OPA with the natural curvature upside down, halfway into the mouth, and then rotate it 180 degrees while continuing to insert it, resting the flange on his lips, ensuring that his lips are not pinched between the OPA and his teeth. I will now look, listen and feel for breathing. And a common error would be if the patient had an intact gag reflex, where you would have to remove the OPA immediately. I will now demonstrate how to insert an NPA. This would be used if an OPA is contraindicated. First, I will maintain the triple airway manoeuvre and measure the NPA from the nostril to the earlobe. I would then apply KY jelly to lubricate the NPA and check the nostril for any obstructions, placing it into the nose using the natural curvature of the nasopharynx, twisting the NPA back and forth, and if I meet any resistance I will not force the NPA past it, as this would be a common error as it may cause perforation or a nosebleed. I would then look, listen and feel for breathing. I will now demonstrate how to perform a laryngoscopy. I'll position myself at the patient's head and the patient in the sniffing position. I will check that the blade and the light on the laryngoscope is working, and I will hold it in my left hand with the patient's head in my right hand. We'll place the blade down the right hand side of the mouth, sweeping across to the left, checking the oropharynx for any foreign bodies. I will then place the tip of the laryngoscope in the molecular groove, making sure that I pull forward, not upwards. A common error would be here if I was to pull upwards, as I could damage the patient's teeth. I will make sure I can visualise the vocal cords and that the airway is clear. I will now demonstrate how to perform assisted positive pressure ventilation with a bag valve mask. I will make sure that the patient has a clear airway and insert the OPA as I previously demonstrated. I will position the patient's head in triple airway manoeuvre and make sure I select an appropriate size mask for the patient's face with a good air in the cushion to make sure that the seal is adequate. I'll place the mask rolling it down from the nose to the mouth with my 5th, 4th and 3rd fingers underneath the mandible, my index finger over the base of the mask and my thumb on the narrow part. I will provide 10 mL of oxygen per kilogram for the patient at approximately 12 to 15 breaths per minute, making sure that there is good rise and fall of the patient's chest. A common error with this technique would be if there was not a good seal and the air was escaping out the side. There would be no rise and fall of the patient's chest and he would be not receiving adequate oxygen.